Okay, let's start on time. Thank you for gathering on this beautiful day outside. First of all, I must say that our speaker is invited to share their personal views. They do not speak for Harvard. And it's my pleasure, a great pleasure to introduce Dr. Jane Zhao, one of the current Takemi fellows. She is an MD physician researcher, has received Master of Medicine from Peking University, and then doctoral degree in public health from University of Hong Kong. And she has extensive list of publication, over nearly 80, half of which as first author or corresponding author. And you can see from her long list of publications that she has been leading international projects with high social impact on sex disparities, on non-communicable diseases, and also nutrition. And today is going to be really a short summary of her large-scale work. And I very much look forward to listening to you talk. And oh, one more thing. This is her birthday. Birthday.
Happy birthday.
And birthday. And okay, let's begin.
Thank you so much, Aya, for this nice introduction. I'm so excited to do the presentation today. Today I'm going to talk about why we should care about sex disparity in cardiovascular health. I'm a Takemi fellow this year, and it will end at the end of May. And I'm also an assistant professor in University of Hong Kong. So first, briefly talk about my background. So in my undergraduate study, I take medical training in Capital Medical University in Beijing, where I major in preventive medicine, had a lot of clinical practice in different hospitals, and also in CDC, which is a major of preventive medicine. But after I got in touch with many aspects in preventive medicine and public health, I'm really interested in nutrition. So that drives me to my postgraduate study in Peking University, where I specifically work on nutrition and obesity and dietary factors. Because it's really interesting to me that in my family, it's so obvious sex disparity in disease risk. All the female members in my family, they are quite healthy, but all the male members, they have either obesity or diabetes or cardiovascular disease. That drives me keep thinking why this happens. Is it due to the dietary factors behind? And in my postgraduate study, I mainly do animal experiments. So although disease can be very precisely controlled, you can let the mice do exactly what you give them, but still there's the big area that confused me is whether this evidence from animals can be applied to humans, because every paper I write, I need to put in the limitation that this evidence are from animals. We are not sure whether it can be applied to people. So we need to be very cautious when interpreting the results. That makes me get frustrated. So that's why in my PhD, I work on population studies, that is to do epidemiology studies in people. And also inspired by the sex disparity that drives me to my career till now. That's the topic we want to talk. So what we know about sex disparity? So we know that there's sex difference in cardiovascular mortality. So this figure shows very clearly that there's very clear trend across years and across areas that men have higher CVD mortality than women. And also some explanations exist. For example, men tend to have more unhealthy lifestyles. For example, men may smoke more or eat more unhealthy food like red meat consumption, lower the intake of vegetables, etc. But studies taking into account of these factors still can't fully explain the sex difference. And also there are some other explanations like men might experience more work-related stress as they are more likely to work outside home compared with women. However, when women entered the workforce in large numbers, there's no significant increase in IHD cases, which doesn't support this explanation. So which leaves a large room to explore what is other reasons behind this. And also, it's quite interesting that although women have lower CVD mortality, women have more complex symptoms when they have IHD. So this figure shows very clearly that we can say women have more shortness of breath or nausea, etc. So this is quite interesting. What is the reason behind? And some explanations like the culture issue, like women may have less access to healthcare because the financial dependence of social restrictions. For example, in some societies, women are financially dependent on men, so men make the decisions. The women may delay their behavior in seeking medical care. But beyond this, actually, you may feel that this might be far away from us, but I want to say, actually, very close to us. And also, I want to share my experience that in addition to these financial issues, even when women are financially independent, restricted by the culture, maybe it's also quite likely that men make the decisions in the family. Like when I was born in mainland China, you know, in China, the traditional culture is when you married, you follow the man. So all the decisions are made by the husband. So that was how I was educated when I was young, and that was how I did when I was in a marriage. But I finally realized it should not be this way. So just an example to show that it's not only financial issues, but also the culture values that shape women's behavior in seeking healthcare. And also there's some research did show that women have less access to healthcare. For example, women who came to the emergency department with chest pain had to wait on average of 11 minutes longer to see a doctor or nurse than men who have the similar symptoms. You may feel that 11 minutes doesn't sound that long, it passed quite quickly, but I bet that when you feel the chest pain, 11 minutes may feel like a lifetime. So you can say it's really difference in the access to healthcare. And also some other explanation might be the social expectation that women traditionally are expected to take care of children, take care of the family members. So it is not only in the Asian culture, but also I think in US, when I talk with collaborators in US, they also mentioned that here is also expected that women to put the social responsibilities first over their own health needs. For example, a mom may want to cook for the children first and then go to see a doctor. So that's another aspect we need to take into consideration. So far, the current issue summarized by the Lancet Women and Cardiovascular Disease Commission, which is published in 2021. I think that's a summary of the past years, but until now, I don't see it changed much. So the CVD in women remains understudied, under-recognized, underdiagnosed, and undertreated, with women underrepresented in clinical trials. So these are what we know. And what I did in my research to add to this field is, in my studies, I identified more potential sex-specific causal factors and also examined the sex-specific role of medications, including Western medicine and traditional Chinese medicine, and also the sex-specific role of nutrients rich in Eastern and Western diets. And also I did health promotion in Asian women in Hong Kong. So I will talk in detail about this. So this is my work in my PhD. So sex hormones have been long considered as a possible explanation for women's cardiovascular advantage. But a lot of work is focused on estrogen. That is, women might be protected by estrogen. And a lot of observational studies show estrogen is beneficial for women, including some very famous cohorts. But then the large randomized controlled trial of Women's Health Initiative shows that actually estrogen has no cardiovascular benefit. Then the alternative is whether it is due to males' hormones like testosterone. So that's basically what I'm doing in my PhD, that we look at the effect of androgens. So at that time, around 10 years ago, androgen is very highly promoted in North America, in US and in Canada, in Australia. And there, the pharmaceutical companies use the advertisement online that is promoting testosterone as a miracle cure that can keep you young forever. I think that's a dream for every person. So it really works, and it started with a low T test. That is, you can take very simple tests, like whether you feel lack of strength, or feel tired, etc., which are actually symptoms of getting when you get old. It is not necessarily due to testosterone. But when you do have this test, you will feel that maybe I need more testosterone. So that's clearly shows that this strategy works, where testosterone is has quite high increase in the prescription in over from 2000 to 2011. But is it really like this? Is this evidence are more from the observational studies? But when we use more robust causal inference methods, like my work used linear randomization, which use genetics as instrument to get causal effect. And also our group did meta-analysis of RCTs. They both showed that testosterone has no benefit, but potential harm. So this is also supports FDA's later warning on testosterone's a potential risk on cardiovascular disease. So later, when I started implementing work, my team is mainly interested in the role of sex hormone binding globin, in short SHBG. I'm really interested in this because many people think it is called binding globin. It must be relevant, must be dependent on sex hormones. It has no impact by itself, but I think it may have some effect by itself, and it is. So in my work, I look at its impact. It's kind of heart disease and chronic kidney disease, well-known risk factor for CVD, and using linear randomization, where we look at both its effect overall and independent testosterone. And we do see that SHBG has sex-specific effect. It has more beneficial effects on men than in women. And it is not, it still works after we controlling for the effect of testosterone. which means it is an independent causal factor. And in recent years, my team is mainly focused on the impact of prevention treatment strategies, specifically on, for example, medications and dietary factors. So regarding medication, actually, we already know that sex may affect an individual's response to pharmaceuticals. For example, men and women have differences in drugs absorption, distribution, metabolism, and elimination, and this pharmacodynamics. However, we still don't have much more understanding about how men and women respond in large clinical trials or many randomization studies, which can provide causal inference. So that's what my work has. Using statins as an example, this is not my research, but it's quite interesting, where it shows that more women reported switching or stopping a statin because of side effects compared with men. So it's kind of known that women are more susceptible to the side effect of statins. And also more women, including high-risk women, reported that their doctor didn't give them information about their risk factors for heart disease compared with men. That is another statement that evidence showing that women's health is not that paid that much attention compared with men. I remember when I talked with a collaborator who works in the hospital. She said that it's a real case happened to her institution that women who went to the doctor with chest pain, the doctor don't feel that is that serious because women have less severity risks than men. So this women is kind of overlooked, and then she didn't get timely treatment, and later she died. It's really sad case. So about the efficacy of cardiovascular drugs, what I did is to look at antihypertensive drugs and lifespan. We know that antihypertensive drugs are very commonly used in CVD patients, and it has been reported to increase lifespan, but it's rarely known whether it has sex difference. So my group did this nonlinear randomization study where we use genetic instruments, which are from the genes, from the targeting genes of the drugs, and we look at its effect. And it's very interesting that we find beta blockers and calcium channel blockers increase lifespan more in men than women, which means men get more benefits from these drugs. And also, because I worked in Hong Kong, and Hong Kong has a traditional Chinese culture where traditional Chinese medicine is quite well accepted. So what I did is to do clinical trial in Hong Kong in the local people, and the drug I used is berberine. Berberine has a long history of use in China. Now it has been extracted from these plants and to make into commonly used Western medicine and in worldwide. And also here in US, it is sold as a nutrient supplement where you can buy very easily in CVS, that's where I bought it, and I take it every day because my trial shows it has benefits in lowering lipids and glucose. So this drug has been long used in China. In the old history, it is used to treat symptoms similar to nowadays called diabetes. But it is not that well known whether it works in men and women differently. So in my team, I applied for the grant and did the first clinical trial in men in Hong Kong. We started with men because men have higher cardiovascular risk. We want to look at the potential benefits in the group of people who are more vulnerable. So after we did the trial, we did meta-analysis of my trial and the previous trials using meta-analysis comparing the trial in men, this one, and also the previous trials in women. And we did find there's sex difference. That's very interesting. So if we look at the impact on HDL cholesterol, we can see that it improves HDL cholesterol in women, but not in men. And also the direction is quite different, and also there's statistical significance there. So now I'm doing another clinical trial in women, and then we can compare the effects in men and women in the same setting, in the same population. And also, we did meta-analysis on glucose metabolism to look at the sex difference on glucose. So here is the result. So we can say that we found that there is sex difference on lowering fasting glucose and lowering hormone IR. So both have statistical difference. If we look at the p-value of the heterogeneity test, they are both lower than 0.05. So that's quite interesting to me. I don't fully understand what explains this. So what we are doing next is to measure more biomarkers like omics, metabolomics, and proteomics to explore the pathways. My team also look at the specific impact on dietary factors. We did a lot, including amino acids, fatty acids, and red meat consumption, etc. So today I mainly want to share the story on L-carnitine and red meat intake. So L-carnitine is a nutrient that is rich in red meat. And also it is commonly used as a nutrient supplement. If you often go to gym, you may notice many people use it because they can help you to build muscles. So what we did, so using linear randomization, we in UK Biobank, which is a very large cohort in UK, we found that L-carnitine is associated with higher risk of coronary heart disease and higher risk of ischemic stroke in men but not in women, which also means that those men who are the main intakers of L-carnitine should be careful when they take this for nutrient supplement every day. And also we did we use UK Biobank to look at the association of red meat consumption and IHD risk. And we did find it, no matter it's unprocessed red meat or processed red meat, it is related to higher risk of IHD in men, but not significant in women. And also we looked into the possible pathways, what might be behind this association. So we did is we used the metabolomics data with over 200 metabolites, and we look at these metabolites which are specifically associated with both red meat consumption and IHD in men. And we found that it's mainly lipid traces that are in the pathway. So actually, most of these previous evidence, including my own research, are using the the data sets in the Western settings. So And also my recent study in red meat consumption, which is published in European Heart Journal, shows that there's differences in different settings. So the association with heart disease and diabetes is different in the Western settings compared to Eastern settings. So that makes me really want to get evidence from Asian population. So that's why I did coordinated Hong Kong Elderly Biobank. It is a nested case control study across all 18 districts in Hong Kong. It is built on the elderly cohort. It is really large cohort with over 180,000 elderly people in Hong Kong. And also it has very long follow-up, over 20 years. So from that cohort, we randomly selected cases and controls and collected their blood samples to build the biobank. And the cases include ischemic heart disease, ischemic stroke, diabetes, and COPD. Each of these cases have 700 cases, and also controls of who don't have the disease, including 750 people. So in total, this will be around 3,500 people. And we are going to measure metabolomics, proteomics, and genetics using whole genome sequencing. So far, we have finished the sample collection for 3,000 people. So we are almost there, and hopefully we can finish this year. And we really welcome collaboration. So I feel the UK Biobank is a really good example of data sharing. So I really want to do that following the example of UKB. So if you are interested in collaboration, do feel free to reach out to me. So, and also hopefully we can get more evidence about sex disparity from this data set in Asian people. So now we can say from the past research and including my research and the published studies, we know that there are sex disparity either in the disease mortality or in symptoms and also in potential causal factors contributing to heart disease, and also people's response to dietary factors and medications are different in men and women. And of course, we can explore more. There's a lot of room here in research. And I feel it's a very exciting research area we can do more here. And also we can see that there's sex disparity in healthcare access from the patient level and also from the attitude of the physicians to patients. And also, to be honest, I feel that we still don't know much about what is contributing to women's health. What is causal factors for women's health? We need to know more about this, and we need to find out more strategies are beneficial. And also about the action part, we can refer to Lancet Commission's suggestion. So our this Lancet Commission is really amazing that it gives recommendations for different areas. Because I'm from Asia, so I want to start with Asia first. So the recommendations for Asia is that the question include misconceptions, restricted education, and cultural beliefs contribute to low awareness of CVD risk and risk factors among women in Asia. So what we need is culturally sensitive initiatives, national campaigns, and public education activities. And also there are some traditional roles and responsibilities persist in many parts of Asia. I'm sure if you have lived in Asia or you have colleagues or friends, you can talk with them. It's very obvious. In which women are caretakers of health, and also often in addition to their domestic duties and employment. And men are decision makers about medical care. And what we can do is we should have more combination of strategic population-based and public policy-based approaches to increase the healthcare for women in Asia and enable women to view themselves as decision makers about their own health. In response to this commission's call for action, what I did in Hong Kong is I did health promotion in domestic helpers in Hong Kong. So they are mostly Filipino helpers. In Hong Kong, the culture is like people are really busy with work and don't have much time to take care of family members. So it's very so the Hong Kong government have a contract with the Filipino government they can immigrate these helpers to come to Hong Kong and to work in Hong Kong, take care of families. So it's really common that almost every family have a helper there to help take care of the older people or children, etc. But they really have low awareness of health. I know this because I do have helpers in my home, and according to my observation, that they often take snacks and a lot of fried food, which is really unhealthy, and they don't know that. They don't know it's unhealthy. So what I did is we gave them the workshop on healthy diet, how to eat healthy, some healthy diet tips, and also we designed some very easy to practice yoga exercises. Then they can practice at home every day. This is me. This is what we did when I was in Hong Kong this January, and we have it really touched me that they really learned very carefully. To be honest, it's more careful than the students I taught in MPH program. And they take notes and they don't sleep in the class. And also we have some very good feedback. This is one of these many good feedbacks that they really realized it's really important for them to take care of themselves and to put health as a priority, and also to stay active. And also, I want to say that when many of them say thank you so much, I really feel that what I offer to them is much less than they give back to me. And also the recommendations for US, I'm sure we care about that. From the Lancet Commission, one issue is prevalence of the metabolic disturbance is high in Northern American women. So what we need is a prevention of obesity and obesity-related conditions. And also there are some minority groups like African American, Hispanic, and Native Americans, etc. They should have more healthcare coverage. And this also needs some culturally sensitive strategies for disease prevention and management. Okay, that's all for my presentation, and welcome your suggestions, comments, and questions. And I'm really open to collaborations, and feel free to let me know if you want to collaborate with us. This is my Hong Kong U email address, which will last for quite a long time. This Harvard email address will expire this June after I leave Boston. So if you want to email me, I prefer you use this email address. And also, this is my Hong Kong website, where you can get to know more of my work. Thank you very much.
Thank you very much, Jane, for really a quick overview of your extensive work. Okay, we welcome any comments, questions.
Yeah, I had a quick question on the red meat impact, and then you had this table
Yes.
of the statistically significant effect. Yeah, I think that was this one.
Yes.
Was it in this that it was controlled for smoking? Because it could be that the men smoke much more than the women.
Yes.
It could be smoking is controlled.
Yeah, we controlled for smoking, as you can see here. We used multivariable logistic regression.
Oh, I didn't see that, sorry. Okay.
It's okay, yeah. But even after controlling for that, it still has its difference. So that's quite interesting. Yeah. So it might be some metabolic factors behind this. Or it can be, not sure whether it might be relevant to social factors. I haven't looked into that part, but it might be interesting to.
Maybe a quick follow-up on that is what is that under like an isocaloric intervention when there's a substitution effect with something else? Men who eat more meat probably are eating less of something else. So if they eat less fish, it's the effect of not having enough fish, not the effect of having too much meat.
Oh, yeah, that's a really good point. Yeah, we in this study we didn't control for other dietary factors, because we did consider of that, but it's I just feel it's difficult to control for all the other dietary factors.
So you would want to probably leave one out as the substitute, and that would be sort of more similar to a trial where people are given more of something but less of something else as a substitution effect. So we have when we are doing this kind of like we have option fish, then you adjust basically within protein intake. So you take the fix the carb, fix the fat within major sources of protein, substitute two, adjust for the other one. So if you adjust for poultry, then it's fish versus meat, and that's a little bit more clear what it is. And then you can add one serving or two servings or something like that. But I had also a question about the interesting nested case control study you have designed. Is that stratified by sex? I would suppose so, but the samples of the cases and controls, is that
Oh, no,
700 is not stratified by sex?
we didn't stratify by sex. We just include all the people who want to participate.
Okay, so it's possible that because of the incidence ratios, you get like 550 male cases of IHD and only 150 female.
But so far as we calculated, the male and female are quite
Balanced.
well balanced. Yes.
Thank you. Maybe last, if I can, just quickly say, the estrogen story you said it's quite interesting. I wouldn't, I guess, conclude that it's not beneficial because I think that's the dominant hypothesis of why women don't have as much risk.
Yes.
In addition to everything else that you mentioned. But as you mentioned, for the healthcare and healthcare usage, usually they are opposite side, and doctors don't suspect them, don't put them on preventive treatments as as much as they should. So I think the estrogen story is still the dominant story. The WHI used high dose estrogen post menopause, so that was a
Yes.
different story, and that had a peak of events which was probably due to effect on platelet aggregation or something else, not necessarily on overall cardiovascular health. So I think that story might still be, at least from the biological perspective, the dominant story, because you already alluded that the testosterone story doesn't hold up much water at all.
Yeah, that's true. That's true. I fully agree. So I realized in recent years there are some arguments about the results from Women's Health Initiative, and some people did some follow-up analysis to show that it might be the initiation of age or the dosage, etc. So I think that would be something quite interesting to follow up. But I'm just wondering whether it is feasible to do that, to test the dosage effect in using the randomization, because it's actually that design can't distinguish the dosage.
Yeah. Thank you.
Thank you so much.
I actually have one question in relation to the first point that Doris asked. It's about the sex disparities of benefits of or preventive effects of dietary nutrients or foods or dietary habits, because you talked about sex disparities of risk. But I wonder about preventive effects.
Oh, that's sensitive. Thank you very much for the question. I think the other side is of the risk factors. The other side is if you lower the risk factors, that would be the beneficial part. For example, say when we say red meat consumption is harmful for men, that means if men lower red meat consumption, they can get more benefits from that. So I think if we change the other way of presenting the results, then will be to explore more preventable, more prevention strategies for lowering the risk. And also, I think something quite interesting that haven't been done that much is like some commonly used dietary factors in Asia, like soil intake, which I think it should be quite beneficial for heart disease, but it is quite on debate. And it would be worthwhile to look into that and see whether it has sex
I was
difference.
also thinking it might be interesting to see the sex disparities and preventive effects of the Asian traditional food
Yes, yeah.
that is close to planetary diet.
Yes. But there are some recent research to look at Mediterranean diet, which is a well accepted healthy diet. They showed using a small trial shows that there are some sex difference in men and women. It seems to benefit more in women on glucose metabolism than women. That's quite interesting.
Thank you.
Thank you so much for your great talk and very, very interesting and exciting. I have two questions. First, I'm really impressed by your presentation about sex disparities. I'm just wondering if age might be important because, for example, men are very active in younger age, but they may not be so active in the later life. And anyway, so I'm just curious if those kind of disparity might change by age.
Oh, that's a really good question. Yeah, I think so. And also according to the previous data, I think the gap does varies with age. For example, after a women's menopause, the gaps actually becomes shorter. So that's why the hypothesis, the story of estrogen has been a mainstream hypothesis that it so obvious that so people will think that it might be estrogen is protecting women from heart disease.
Yeah, that's maybe our new collaborative project because as you said, if sex-related hormone is so important, the effect might be different between age.
Yeah,
But,
exactly.
if
Exactly.
not, it's not. So, that's very interesting. So
Yes.
I have another question about implementation. So I think, our overall goal is prevent disease like a cardiovascular disease and cancer. And based on your previous research and ongoing and future research, what do you think about how we can reduce disparity, what we can do to prevent disease based on the disparities?
Oh, that's a really good question. I think it's already on debate that whether we should have sex-specific dietary guidelines or clinical guidelines. I think years ago, there's already publications in JAG, which is a leading journal in cardiovascular disease. They argued whether we should have sex-specific recommendations for men and women. And also there are some arguments like regarding the use of statins, whether women should be given a smaller dosage, given women have more side effects. But so far, we haven't seen any guidelines published sex-specific recommendations, possibly because the evidence is not that much. So when the guidelines are made, they often need a lot of supporting evidence. So I think that's part of the reason behind this. But I think in the future, the way to forward is really we should have sex-specific guidelines if we do say the sex differences in the people's response to medications and response to therapy factors. And also another part is given some of the differences are due to the healthcare access and healthcare awareness, we should really increase women's health awareness and to improve women's health. I think that part is something we can do right now, and it will work. According to my experience, I believe it will work.
Thank you very much.
Thank you.
Thank you for your great talk, and I'm very impressed about the social expectation for women and how it impacts for the women's health for the cardiovascular disease. And personally, I don't think there is a disadvantage for the social expectation for women. For example, I have two kids, small kids, and I feel the lifestyle is much healthier than that I had not kids, because I feel sleep earlier time and wake up early morning, and taking kids is one kind of exercise. So have you ever examined the beneficial effects of child caring for the cardiovascular disease?
Oh, thank you so much for sharing. That's very interesting. In my research, I haven't looked into that part, but I'm going to do more about that because I think the social factors will be a quite important part. And also, I think everyone's situation might be different. For example, I remember during the COVID pandemic, where the kindergartens are all shut down, where at that time I reviewed a grant application. The applicant is a woman, and she specifically said that my research was disrupted due to the COVID because I need to take care of children. The kindergartens are shut down. That really impressed me because it's the first time I see some people put that in the CV. But also it shows something that women are, and also there are studies showing that women are more affected when this social isolation occurs, and women are more expected to take care of children and to sacrifice their own work or their own life. Yeah, I think maybe people have different situations, different responses in their life, but in general, the social norm is like this, and so that's some kind of what affected the healthcare.
Maybe just quick point, I guess the flip side of it is the impact of the pregnancies on cardiovascular outcome. Irrespective of if there is cardiovascular abnormality involved, gestational diabetes, pregnancy-induced hypertension, we know that's definitely not good. But even without that, some of our colleagues here, like intersection of reproductive health and cardiovascular health is an interesting area. How many our pregnancies are protective, or if things don't go wrong, they are protective. But on average, we know during each pregnancy, people barely gain, or they usually gain even in good places with good care, 30% extra weight. So the weight gained during pregnancy doesn't fully recover. So each pregnancy
Yes.
flips up their weight by 30%.
Yes.
So yes, kids may have some additional benefits mentally and otherwise with respect to activity and other things. But pregnancy itself might be a stress on the system, and how much of it gets back to normal and recovers, I think
Yeah,
this is
that's-
still a question mark.
Thank you very much for the comment. And also actually from the evolutionary biology perspective that which says that reproduction trades off against health. That is, if you put more energy on the reproduction part, then your health is sacrificed. So it's a trade-off.
So also we need to consider the contraceptive.
Yes,
yes.
yeah.
Okay, thank you very much for the active discussion. Thank you for tuning in.